So I highly recommend you watch that little video clip on Brian Charnley. I think it looks a little cooler than the cats you might have been shown elsewhere. And maybe you've already seen the Brian Charnley, sort of self-portraits. But I just find it one of the more interesting things out there. In regard to art and mental illness. That being said, where I lived last, Baltimore, Maryland, there is a sort of an odd art museum. And in it, they have an entire wing of art that's been confiscated from psychiatric wards. And it is just absolutely fascinating. I highly recommend you visit that museum if you're ever in Baltimore. They also have all these crazy sculptures and stuff. It's just fascinating. But anyway, in the unit on schizophrenia, I want you to describe the symptoms of schizophrenia and be able to identify which neurotransmitter is associated most with the positive symptoms. I'd also like you to describe the pros and cons of the dopamine hypothesis of schizophrenia, which is, quite limited. I'd like you to describe hypofrontality and neuroanatomical changes that accompany schizophrenia. Describe the glutamate theory of schizophrenia and the effects of NMDA receptor antagonists, and describe the integrative model of schizophrenia. And again, I am going to focus on the neurobiology here. If you want the DSM criteria, diagnoses, all these things, not my expertise. Go take abnormal psych. Schizophrenia affects approximately 1% of the population. It's hallmarked by dissociative thinking or impaired logical thought. Other symptoms include auditory hallucinations, personalized delusions or false beliefs, and changes in affect or emotion. I'd also like to point out that schizophrenia, was really first described as a cluster of symptoms and possibly disorders. It's one thought that still intrigues me. I'm just a neurobiologist here. I'm not really, an abnormal psychologist, certainly not a clinician. But, I think it's very true. I don't think you would find many people there that would disagree with the idea that, the symptoms in between or across schizophrenic patients can vary quite a bit based on how much positive, negative, and cognitive symptoms they show. Which might suggest, that schizophrenia still could be a catch-all, of different things that could be treated better with different approaches. Just a thought. Positive symptoms are abnormal behavior that is gained. These would include hallucinations, delusions, and excited motor behavior. Negative symptoms are the result of loss of function, such as slowed thought and speech, emotional and social withdrawal, and blunted affect or emotional expression. And more we're starting to also recognize that there could be a cognitive cluster of symptoms. Like slowed thought could actually be more appropriate in that cluster. So just a review of abnormal psych here. The positive symptoms, hallucinations, these are almost always auditory. Auditory hallucinations are caused pharmacologically by NMDA receptor antagonists, more the dissociative drugs, whereas LSD and MDMA tend to produce more visual hallucinations that you do not see in schizophrenia. So, whether or not that's related to actually the cause of these auditory hallucinations remains unknown. But, the idea of NMDA receptor dysfunction is certainly intriguing. There are also commonly delusions of grandeur and internal persecution, disordered thought processes, and bizarre behavior. Whereas negative symptoms can include social withdrawal, flat affect or a blunted emotional response, anhedonia, loss of pleasure, reduced motivation, poor focus on tasks, alogia, reduced speech output, and catatonia, or reduced movement. Schizophrenia is partly heritable. There are family twin and adoptive studies that show higher incidence among biological relatives. In this case, monozygotic or identical twins share identical genes, and dizygotic fraternal twins have half the genes in common. So using twin studies, we've been able to show that schizophrenia is about 50% purely genetic. And I'll come back to that purely idea here in a minute. So if both twins suffer from schizophrenia, they are concordant for the disease. If one member of a pair has it, they are discordant. For identical twins, the concordance rate is 50%, pointing to a genetic factor. Here, you can see the relationship between your relatives and your chances of having schizophrenia. Again, with a monozygotic twin, there's about a 50% concordance rate. Now, one idea here, though, however, is the idea of epigenetics. So, we're about to go over some environmental influences that have been tied to schizophrenia. A top one in my mind is viral infection during prenatal development or very early neonatal development. But, the idea here is that viral, interaction, or maybe even inner city stress, pollution, these sorts of things could possibly lead to epigenetic modification to turn on, genes leading to the expression of schizophrenia. So, if epigenetics is how environmental factors are producing changes in schizophrenia, one could argue that schizophrenia is 100% epigenetic or genetic if you include epigenetics. That being said, you have to see the difference here between purely genetic and environmentally induced epigenetics. So whether or not epigenetics is the reason or a link here, is somewhat beside the point. The rate of discordance suggests that other factors also contribute to the development of schizophrenia, including environmental influences, developmental difficulties such as low birth weight and impaired motor coordination, and also viral infection at birth or while the baby or infant is still in the womb. There's definitely not one gene that's involved, though. There's a very famous study that came out a few years ago that demonstrated that there are a little over 100 genes that can be implicated in schizophrenia. Paternal age may also be a factor. Older fathers are more likely to have a child with schizophrenia. Brains of schizophrenic patients show structural changes, including the cerebral ventricles becoming enlarged, especially in males, and remain so after the initial disease onset. It's thought that this isn't really the ventricles getting larger as much as it is the cells around the ventricles being lost. The enlarged ventricles predict a poor response to drug treatment, which I think makes a lot of sense. So about that cell loss, again, you see neural loss over the age span, and as a result, the ventricles become larger and larger. Why do we keep electing old people to become president and trust everything that they say? I don't know. But, patients with schizophrenia, this is largely augmented. Here's just MRI scans demonstrating the enlarged ventricles being even larger in male versus female, and you only see the augmented enlargement of the ventricles in the twin or identical twin that's affected with schizophrenia. So this would be an example of discordance. The hippocampus and amygdala are smaller in schizophrenics than in most people. And really one of the first things that you might associate with schizophrenia is abnormal pyramidal cell development in the hippocampus, particularly the ventral region of the hippocampus. Here you see a disorganized arrangement, which has led to really there aren't very many good animal models of schizophrenia, so it's very difficult to study. Again, you can't do much in humans to really get at the neurobiological bases and these sorts of things. But one idea here has led to the development of what is known as the neonatal ventral hippocampal lesion model of schizophrenia. So here, you either just directly lesion, or now it's become even more common, based on this idea that there could be viruses that could be inducing disruption early on, viral exposure to the vitreal hippocampus. And that leads to this same disorganization of pyramidal cells within this region. And now the hippocampus, remember, going back to development from the long tube, it's very much tied to the development of the frontal cortex. And again, these two regions wire and fire together and are also, of course, very important in declarative memory, higher executive function. Guess what's impaired in schizophrenia? And you also have this idea of a hypofrontal frontality, or a hypofunctional frontal cortex that would have an inability to influence the rest of the brain. So one idea of the developmental idea behind schizophrenia is that maybe this disruption of the ventral hippocampus is the first domino, and then that would then lead to development to disruption in the hypofrontality and a underdeveloped frontal cortex. This is just a cartoon from your book illustrating the disorganized pattern of pyramidal cell expression in the hippocampus, which would then again could possibly lead to hypofunctionality and a poorly developed frontal cortex. More theory than something that's known, but I do think it's an intriguing theory. So whether or not it's a second domino following the development of a disorganized frontal cortex, it's very clear that in some schizophrenic patients, there's a loss of gray matter in the frontal lobes. This has led to the hypofrontality hypothesis, suggesting that schizophrenia may be caused, or at least related to, underactivation of the frontal lobes. In the 1930s, psychiatrists began performing what are known as lobotomies, where you detach the frontal lobes from the rest of the brain to treat schizophrenia. This, happened by, for quite some time. Many children, adults, were lobotomized throughout America. And, I'll show you a little clip on that here in a minute. But luckily in 1950s, schizophrenics began receiving treatment by chlorpromazine. Chlorpromazine was developed in France. Some surgeons were experimenting with drugs to be used during surgery because there really weren't great drugs to be used to anesthetize, patients. And again, a lot of this was related to warfare and these sorts of things, as it typically is the case. It's why we have a hypodermic syringe and like why we have so many things. But anyway, the chlorpromazine was first developed, observed to sort of calm or cool patients. And that led to some thinking that it could be useful in psychiatric medicine. And it was then used to treat schizophrenic patients. And it was first described to have cooling effects. And the reason that it was described that way is one of the crude treatments at the time. And now, granted, most of the treatments that we have right now would be considered crude in 50 years. But at the time, they would actually, in some places, submerge schizophrenic patients in freezing baths or baths of ice water because it would cool them or calm them. So that's why chlorpromazine was first described as a cooling agent. Neuroleptics, or antipsychotic drugs, primarily work by blocking the dopamine D2 receptor. This led to the dopamine hypothesis of schizophrenia, which states that schizophrenia may result in part from excess synaptic dopamine or increased or more sensitive dopamine receptors. And all of those sort of add-ons had to occur because there have been very few studies, if any, that have definitively demonstrated that there is increased dopamine release in schizophrenic patients. So while we lack a lot of direct evidence of this, again, it's sort of difficult to measure dopamine levels in humans. You can do this sort of indirectly by looking at radical applied displacement PET imaging. But this isn't exactly perfect. You're not really measuring dopamine directly. And if you're measuring this effect, after years of having schizophrenia, maybe there has been sort of a self-regulation happening, so it's harder to see. I don't know. But some of the proponents of the dopamine hypothesis really push indirect observations, one of them being amphetamine psychosis. So if you give a patient or a subject, or really what's more likely to happen is a drug user uses too much amphetamine or methamphetamine or bath salts, whatever, which are synthetic cathinones, a synthetic analog of the main component of khat. But anyway, these drugs that increase dopamine release can produce temporarily psychosis. That being a more positive symptom associated with delusions and these sorts of things. So amphetamine promotes the release of dopamine and prolongs its action by blocking dopamine uptake. And this is some indirect evidence supporting the dopamine hypothesis of schizophrenia. All the various antipsychotic drugs that are now classified as typical neuroleptics are dopamine D2 receptor antagonists. It also turns out that almost all the atypicals also have some sort of affinity for the dopamine D2 receptor as well. But this is most clear in the typical neuroleptics. The clinical effective dose of a typical neuroleptic can be predicted by its affinity for the dopamine D2 receptor as well. And haloperidol has a great affinity for dopamine D2 receptor and is widely used to treat schizophrenia. One correlation that has been reported by psychiatrists is that the typical neuroleptics that are very good at blocking D2 are particularly effective at treating positive symptoms of schizophrenia, like psychosis, like you might see be induced by amphetamine. So again, it could be a subset of patients that are most effective at being treated by the typical neuroleptics might have these alterations in dopamine transmission. And whether that's increased release or supersensitive postsynaptic receptor, and that's sort of like the one that people go to after failing to observe the increase in dopamine levels. But to be fair, it remains unsolved mystery. So Philip Seaman was really the first to demonstrate or report that the efficacy of a dopamine D2 receptor and the dose required for that efficacy is correlated with dopamine D2 receptor activation. This is really probably the most robust or the greatest evidence for a dopamine hypothesis in schizophrenia is just simply that dopamine D2 receptor antagonists are effective at treating symptoms, particularly the positive symptoms of schizophrenia. I've seen Seaman talk, a few years ago. If you're looking for, sort of his protege, I might look up Kshitij Kapoor, Kapur, if you're interested in reading or exploring more of this. So there are obvious problems with the dopamine hypothesis of schizophrenia. One is that drugs that block dopamine D2 receptors much faster, or the drugs block the dopamine D2 receptors much faster than the symptoms are actually reduced. Sound familiar to depression and SSRIs, anybody? And some patients show no change. They're unresponsive to the dopamine antagonists. Again, I think going back to this idea that there could be, slight differentiation or variations in neurobiology. And, similar to my arguments with antidepressants, it would be great if we could use pharmacogenomics or some other mechanism to computationally predict who will be most effective in one treatment versus the other, rather than just having to treat every poor patient with a ringer of drugs to see what works. Hopefully by the time our great grandkids are psych patients, huh? Antipsychotic drugs have long-term effects such as dyskinesia, a distortion in voluntary movement. Tardive dyskinesia shows repetitive movements involving the face, mouth, lips, and tongue, and is due to upregulation or supersensitivity of the dopamine D2 receptor. This is assessed using AIMS, the Abnormal Involuntary Movement Scale, and the symptoms look pretty similar to Tourette's, which again is associated with supersensitivity of the dopamine D2 receptor. In this case, usually thought to be the heteroreceptor or postsynaptic receptor, rather than the autoreceptor. So a couple of decades ago, a new class of drugs that successfully treats schizophrenia was developed that doesn't necessarily support the dopamine hypothesis. This would be atypical neuroleptics like clozapine that act on serotonin receptors in addition to other receptors throughout the brain. However, almost all of these still have some affinity for the dopamine D2 receptor. Some actually have been shown to increase dopamine levels in the frontal cortex, suggesting that there's something going on with dopamine here, as well as these atypicals. But they do have additional effects on the serotonin system, and it is thought that they are more effective at treating the negative symptoms. Some of these might be depressed mood, these sorts of things that could be more associated with serotonergic deficits. So here's a graph or illustration from your book showing binding affinity, what receptors basically the various antipsychotics hit. You can see the typical neuroleptics there, like chlorpromazine, which was the first, haloperidol, which was one of the first to have a really high affinity for the dopamine D2 receptor, and then the atypicals with clozapine and risperidone being two of the more famous. Show me the atypical antipsychotic here that isn't hitting the dopamine D2 receptor. First of all, you can't. You can see that the serotonin receptor and other receptors are targeted by both the atypicals and the typicals. So, this idea that the atypicals are, completely different is, not exactly accurate. And, they do have affinity for the dopamine D2 receptor as well. And, there's this idea, I guess there was this idea a couple of decades ago that the atypicals would be so much better and safer. And that's actually the opposite of the truth. Atypicals can cause something called agranulocytosis, or a loss of white blood cells, which can kill you. PCP is a funky drug because it produces some symptoms of schizophrenia, both positive and negative. As an NMDA receptor antagonist, like most NMDA receptor antagonists, including even dexamethasone from the cough medicine, and ketamine, all of these drugs produce auditory hallucinations and a dissociative hallucinatory state. Other NMDA receptors like ketamine also produce similar effects to PCP, which is part of the basis of the glutamate hypothesis, suggesting that schizophrenia is partially caused by underactivation of glutamate receptors. This hypothesis is also supported by the actions of atypical neuroleptics that work on serotonin receptors, which in turn make metabotropic glutamate receptor transmission more effective in certain cases. An integrative model of schizophrenia suggests that schizophrenia will develop if a compromised brain is exposed to environmental stressors. So a genetically susceptible individual could be exposed to things like influenza or a virus, city life, including pollution, increased stress, and a loss of oxygen at birth, which can also occur in cities, particularly those plagued with high levels of pollution, like Chile, for example. As you can see, living in a large city, does increase the risk of schizophrenia. Why that is remains, somewhat of a mystery. Many reasons are out there. I guess I personally am a fan of parts of this, virus influenza idea. Obviously, I brought it up several times, but that's just a wild guess. I don't know. I find it an intriguing possibility, but it's probably more than just one environmental factor. And then whether or not that is actually inducing epigenetic modification and thereby getting back at genetic causes and influences, remains to be determined. But again, I think it's all pretty intriguing.